Good afternoon, participants. Welcome to this session on nursing series. We are presenting today ECG, an important diagnostic tool. With us here presenting this very important topic in our care of our patients is Njenga Kamami. Njenga Kamami is an RN in cardiothoracic ward 4B in KNH. Myself, who is moderating this session, my name is Milinya Minette. I'm an RN in the neurosurgical unit 4C KNH. Welcome to this session. Njenga Kamami.
Thank you very much, Lynette, for a wonderful moderation. And also want to thank every last one of us who have been able to join this important webinar. So stay tuned. We will be learning or probably even telling us what we already know so that we remind ourselves. Before I start, I want to say that ECG is, as the topic says, there is an important diagnostic tool that probably should be in every A&E, every cardiothoracic, every cardiac unit in this land, because of late we have gotten a lot of patients who are having non-communicable diseases, most specifically heart-related issues that we need to be having an ECG machine so that you're able to help as and when our patient requires. So ECG is as easy as ECG. You should not get worried once you get an ECG strip, and because once you get to know what needs to happen, you're well able to be able to help our patients. So let's go and let's look at our learning objectives for today. So we'll look at the basic approach to interpretation of an ECG strip. Then we will look at features of an ECG, and then we'll explain how to calculate heart rate. PRI is PR interval. We look at what it is. We'll also look at QRS complex when you're given a 6-second strip. So let's delve in because you have quite a number of things to cover. I want to believe during our, whether you did nursing or probably clinical medicine or medicine, probably you were able to look at the conduction of the heart. And that is actually the cascade of how the impulses actually flow. If you can, I don't know that you're not able to see my cursor, but from the first arrow there, of course, they start from the sinoatrial node. And because of the automaticity, cardiac cell can act as a fail-safe means of initiating electrical impulses so that you'll have backup cells, basically which are intrinsic pacemakers. Of course, they are arranged in a cascade fashion so that the fastest cell fires faster, which is our SA node there, then goes down to the AV node, atrioventricular node, which fires at 60 to fires from 40 to 60, sorry. SAS fires from 60 to 100. Then, of course, from there, you go to the Purkinje fibers at the tail end that fires at 20 to 40 beats per minute. So basically means that if any part of the heart fires faster, it becomes the dominant pacemaker. But of course, the natural order is that the sinoatrial node fires faster all the way to the Purkinje fibers. And of course, just a repeat of what I've just said, that the inherent rates, as I just said. So that meaning that if the flow starts from where you can see from the sinoatrial node, the 60 to 100, when it gets to the atrioventricular node, it slows. This allows the infilling of the atria and actually the emptying it again. So it allows the atria to empty into the ventricles. Okay, it's about 0.15 seconds of delay that helps in the filling of the atria. Okay. So that's basically what I was saying. The sinoatrial node in terms of their rate, the atrioventricular node in terms of their rates, and the ventricular cells. So that meaning every part of the heart becomes very important, so that when the ventricles are firing faster than the sinoatrial node, then it means there is a challenge in that heart. Okay. So now let's look at this cardiac conduction and how it flows. So the cardiac conduction starts from the sinoatrial node, okay? As you can see, sinoatrial node basically represents the depolarization of these waves from the right to the left atria, stimulating atrial contraction, producing a P wave on the surface ECG. As you can see, the P and of course the color code that you have seen there on the right and the left. Then of course, again, it flows out to the atrioventricular node where I said earlier that it slows, allowing time for the atria to contract and blood to be pumped from the atria to the ventricles prior to the ventricular contraction. Conduction time through the AV node accounts for most of their duration, the PR interval. We look at what PR interval is as we move on. Okay. Then, of course, after the atrioventricular node, it goes through the bundle of His, proceeding through the left and right left bundle branches, as you can see there on the illustration. And of course, as you can see that the gray mark has moved now across that line. After leaving the left and atrial bundle branches, the impulse passes through the Purkinje fibers, which are interlacing fibers of modified cardiac muscle. On the ECG, this is represented as a Q wave, as you can see where the gray mark is. And of course, after that, the impulses passes quickly through the bundle of His, the left and the right bundle branches, and the Purkinje fibers, leading to the depolarization and contraction of the ventricles. As you can see, that color coding of yellow and correspondingly, the QRS on the gray mark so shows that there is an activity that is happening in the ventricles. The QRS complexes on the ECG represents the depolarization of the ventricular muscle mass. Yeah, and remember that the left part of the heart is the muscle is quite enlarged because of the pressure that it undergoes as it tries to push out blood from this particular part of the heart. Again, as we move on, following the QRS complex, the ECG of course shows like it has gone into a plateau, as you can see on the gray wave, which lasts for several milliseconds. And of course, then what happens is that you get something called repolarization of the ventricles, generating a current in the body to produce that T wave, the upward deflection. Of course, this takes slowly, thus generating quite a very wide wave, which actually represents the T wave. That basically shows that shows the general movement of your leads. The general movement. Sorry, I think I moved faster. Needed to show that one. Yes, thank you. The general movement of the impulses from the SA node all the way to the Purkinje fibers, and of course, now the general movement of the impulses across this myocardium. Okay, so again, in the next slide, I'm sorry, my system is a bit slower. This is just to illustrate that when your impulses is moving away from the electrode, you will get a negative deflection. As you can see, the first black structure there is facing downwards. In the event that the impulses is actually crossing to go to the positive mark, you'll get a positive deflection, as you can see on the positive side, meaning that in the event that the electrodes are moving, or the impulse is moving away from the positive electrode, you will have a negative deflection, of course, because of many issues. Okay, now we have looked at the conduction of the heart. Now let's look at the types of leads that we have. So when you're connecting a patient to an ECG, of course, you will have either you have 5 leads, you have 3 leads, or you have 12 leads. Let's look at this. So what is shown there is a patient probably being connected on a 12-lead ECG. A 12-lead ECG has several ECGs. The bipolar leads are lead 1, 2, and 3. Bipolar means that they are able to produce a second lead, which are normally called the unipolar leads. AVL, AVR, AVF are unipolar leads, one lead. And when you combine the two leads, the bipolar and the unipolar, they become the standard leads. The bipolar leads, you'll also call them the limb leads that are connected as lead 1, 2, and 3. And lead 1, 2, and 3, they're able to generate for you to give you AVL, AVR, AVF. And now on the chest, you connect the chest leads. That is V1 to V6. We'll be looking at how you connect them. And then now you're able to get all your leads on this patient of yours. Okay. So this is what I was explaining about the standard leads. The standard lead 1 is connected so much so that the impulses flow from right arm to the left arm. And basically, if the patient doesn't have any anomaly, you will have a positive. The patient will have a positive deflection. The lead 1 will be positive. Then you have lead 2 flowing from right arm to left leg, because the impulses, like I said earlier, it is from negative to positive. More often than not, you'll get a positive deflection. Then from lead 3, you'll get from left arm to left leg. This one, you will, they are called, you do not get, they are called biphasic lead, meaning it is neither negative or positive. It is there in between. And then lead 1 gives you AVR, lead 2 gives you AVL, and lead 3 gives you AVF. So in total, you get 6 leads, and you call them the standard leads, standard limb leads. Good. So let's now look at how you place your ECG as the 12 lead ECG placement. So number 1, you place it on 4 intercostal space right. And of course, on the marker, what you need to know is that you locate the manubrium, or the angle of Louis. Then you go 1, 2, 3, you go to the 4th intercostal space. Then you connect your V1. on the right side. Then V2, you connect it on the same plane, fourth intercostal space on the left side. Then you don't connect lead 3, you connect lead 4, mid-clavicular line, fifth intercostal space. Then lead 3 is connected between lead 2 and lead 4. Then on the anterior axillary line, on the same plane as lead 4, you connect lead 5. Then lead 6 is on mid-axillary line on the same plane, that is fifth intercostal space. And then from there, you're able now to generate to be able to read your ECG. So lead V1 all the way to V6. Remember V1 is connected on the fourth intercostal space right side of the sternum. Then lead 2 you connect on the same plane, fourth intercostal space on the left. Then you connect lead 4 on the mid-clavicular line. Then lead 3 becomes in between lead 2 and lead 4. And anterior axillary line, you connect your lead 5, and then you connect your lead 6. So in an ECG, this is you'll get now the groupings of your ECG. So you'll get your lead 1, your lead 2, your lead 3. In that progression, lead AVR, lead AVL, lead AVF. This is how your ECG will follow in terms of the tracing on your ECG paper. Then V1, V2, V3, V4, V5, V6. And because today it's an introduction, we might not really delve into it, get to know much more, but because we'll have another time, we'll come and delve into the groupings of these leads. Now, let's look at the anatomy of the heart, where these P, these Q, these R, what exactly do they represent? So the P wave represent the atrial activation, that is the passage of impulses from the sinoatrial node to the atrioventricular node. As you can see, it is illustrated. There is the baseline, or what you call the isoelectric line. Then the first deflection, the first positive deflection upwards becomes your P wave. And like we have said in the first bullet there, it is the atrial activation, the activity of the atria, the passage of impulses, and of course, at the end of the day, you'll get mechanical activity will be a contraction of the atria. And I want to be quick here to say, though you have 4 chambers, there is the atria, the right, left, and then you have the ventricles, the right and left. They do not contract as 4 chambers, but the contraction is, and the pacing is a dual pacing, and even the contraction is a dual contraction, so that because of the passage of these impulses across these 4 structures, you are able to contract, and the impulses are able to pass as 2 units. So the 2 atria, they contract as 1 unit, and the ventricle contract as 1 unit. So you have dual pacing of the atria and dual pacing of the ventricles. So the second bullet there is a PR interval, which is the onset of atria activation, which is from where the P starts to where the QRS starts. That's your PR interval, okay? Then the QRS complex, of course, is where the Q starts, which represents the electrical ventricular activation, the QRS. And of course, you have the QT interval, which shows the duration of ventricular activation and recovery. And now when you talk of the ventricular activation here, you're thinking of the filling and the emptying of this ventricle. And of course, the passage of impulses across the ventricle from from where we started at the AV node all the way to the Purkinje fibers. Of course, on that structure, there is the U wave, which is the last one there. U wave represents electrolyte imbalances of your patient. Probably you need to, sorry for that. You need to check probably on your electrolyte imbalances of your patient once you see a U wave. And when you see it, mostly it is upward deflection. It is positive in nature, the U wave. Okay. So now let's delve into the ECG and how you are able to calculate the rates for your patient. Now, the common ECG machine is the default speed is at 25 millimeters per second, okay? So the stylus pen, because the ECG paper is thermosensitive. Once it is connected, the speed that is set is meant to be at 25 millimeters per second. 25 millimeters per second, it means 1 millimeter is one small box. Basically, it means that this stylus pen will move 25 small boxes in 1 second. Maybe I need to pause there and ask then if this stylus pen is moving at 25 millimeters per second, how many millimeters or how many small boxes would it have moved in 60 seconds? You can interact with us even as we continue on the Q&A and even the chat box to get to see that. So then 25 millimeters per second, and we have just said one small box is equivalent to 1 millimeter. For you to get 0.04 then, it means it is one small box divided by the 25 small boxes, you'll get the 0.04. 0.04 per second means that one small tiny box, the duration it takes this stylus pen to move is 0.04 of a second, okay? Now, the 0.2 seconds represents the 5 small boxes, which is 5 times 0.04 to give you 0.2. The other thing that is showed there is in terms of vertical is the voltage in millivolts. One small box is equivalent to 0.1 millivolts. So meaning that 5 of them will be 0.5 millivolts, and that's what is shown there is a half a millivolt. Okay, so in terms of time, the horizontal line represents times in seconds. Vertical line represents voltage in millivolts. So 5 millimeters is equivalent to 0.5 or equivalent to half millivolts. And I think this is what I have been explaining. I've been explaining here that the paper speed is at 25 millimeters per second. And in terms of, so meaning that one small box will be 0.04. In terms of millisecond, that is 40 milliseconds. And then 5 of them will be 0.2 of a second or 200 milliseconds. And of course, what is shown there is that P wave represents, of course, the activity that is happening at the atria. And of course, we have shown in terms of distance, one small box is 1 millimeter. 5 of them will be 5 millimeters. And of course, in terms of voltage, we see one small box is 0.1. So then when you have 10 of them, you'll have 1 millivolts. Okay, these are important numbers, especially when you are setting the calibration of your machine every morning before you start your ECG. Good. So when you're reading your ECG squares, of course, I'd explained the horizontal axis will represent time in seconds. I said one small box is 0.04, And in terms of milliseconds, that will give you 40 milliseconds. And one big block of 5 small boxes is equivalent to 0.2 of a second. In terms of milliseconds, what have been shown there is 200 milliseconds, okay? And of course, it is important in terms of, especially for patients who have pacemakers or internal ICDs, internal cardiac defibrillators. They're able to calculate the intervals they calculate actually the intervals in milliseconds and not in rates. I thought that is important for us to get to know, okay? So that now you're able to pick up any condition that your patient may be having. So let me be quick to say that there's something called the PR interval, and that because these rates or this timing becomes very important. PR interval is a passage of impulses from where the P starts to where the Q starts, and actually represents the passage of impulses through the atria. The normal PR interval is 0.12 seconds to 0.2 seconds. In terms of milliseconds, is 120 to 200 milliseconds. Those numbers become very important. Okay, so let's look at how you label your ECG. Okay, of course, we've said the first deflection upwards becomes your P wave. Your P wave can either be positive, biphasic. Biphasic means it is neither negative or positive, or negative. Negative, of course, because of probably the anomalies that your patient may be having. So that's the first deflection upwards or even downwards becomes your P wave. Now, in terms of QRS, the second structure, Q wave is the first negative deflection wave. Then from there, you have your R wave, which is the positive deflection upwards. From there, you get your S wave, which is the first negative deflection after R wave. Then you get your T wave in the second structure. Your QRS goes to the baseline or the isoelectric line, and then there is a positive deflection upwards, which becomes your T wave. So your T wave here represents the ventricular repolarization, basically meaning the resting of this ventricle before you go to a second cycle. So ventricular repolarization. So that's how we label our ECG. PQRST, discovered by Dr. Eindhoven, a Dutch physician, a Dutch physiologist, many years to help in terms of issues to do with cardiac. So P, for now, we know it is atrial depolarization, represent the atrial activity. QRS complex represent the ventricular depolarization, the passage of these impulses through this ventricle. And T wave represent the ventricular resting phase. Okay, the T wave. Okay, so we move forward. Now, one of our objective was the ECG interpretation. So we have looked at the preliminaries, and now let's look at the ECG interpretation. Now, how do you move forward to interpret your ECG? Number one, you need to check on the name of your patient, very important, could be for a different person. Then the time and date becomes important. Date of birth, remember again, ECG, because of issues with age, you might get issues. You need to know the age of your patient. Indication, the chest pain or any other indication. Does your patient have any other previous ECG? The other thing that you need to check on your ECG is the calibration marks. calibration marks to check whether you have calibrated in terms of the size of the size of the ECG. Basically you should have 10 millimeters or equivalent to 1 millivolt. We said one small box is equivalent to 0.1 millivolts. So you should have your ECG having 10 millimeters or equivalent to 1 millivolt. Then you want to check on the rate. You want to check on the rhythm. You'll check on the axis. We'll also check on the elements of the tracing in each lead. So now we'll delve into the ECG and how you interpret. And the first thing that we will do is that the first thing we'll do is you will look at the rate. Okay? How do you calculate the rate? So number one, of course, how you calculate the rate, you count all those QRS that you can see there, then you multiply by 10. Then you multiply by 10. So if you were to count like this one, you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. Then you multiply by 10. These are very fast rate, very fast rate. The other way is, of course, using the small boxes method, which is the 1500, 60 times 25. We said 1 second, you move 25 millimeters. So if you did 60 by 25, you get 1500. So then you look at the RR interval, then you divide by 1500, then you'll get your rate. So the other one would be, of course, you look at the large boxes. Large boxes is 5 boxes, which represents 0.2 of a second. And since 1 minute has 60 seconds, so 60 seconds when you divide by 0.2, it gives you 300. So again, you look at the RR interval, you count the boxes in between, then you divide by 300, then it will give you the rate. So the other method is, of course, you count 30 big boxes, which is equivalent to 60 to 6 seconds. Then you multiply by 10. You multiply by 10. This one also is a very slow rate. 1, 2, 3, 4, 5, 6. Actually, it's normal. The other one, you count from where the first marker is to the other last marker. You count 30 big boxes. Then whatever you get there, the RR, you multiply by 10 to give you the rate that you're looking at. Okay? So like this one now, you look in terms of how you estimate your rate. I've said you look at the RR interval. We have already seen that 1 minute is equivalent to 300 big boxes because it's 60 divided by 0.2 or 60 divided times 5. It gives you 300 big boxes. Then you divide by the number of R's in between, a number of boxes, sorry, that are in between. So like now, this one, the 2 arrows, it represents 2 big boxes. If you divide it by 300, it will give you 150. If the boxes were 3, it will give you 100. If boxes were 4, it gives you 75. If the number of boxes were 5, it gives you 60. All the way to 10, it gives you 30. So that's one way of getting to calculate your rate. So your rate will either be normal is 60 to 100, will either bradycardia is anything that is less than 60, tachycardia anything above 100 per minute, and there will be given the Seattle criteria to calculate the abnormal ECG findings in the athletes. For you to get the ECG findings in this athlete, is any ECG finding that has profound bradycardia less than 30, then when you have sinus pulses of more than 3 seconds, meaning that you have a place whereby there is the P waves. There's no QRS, there's no P wave, that is a sinus pause. Then your patient has profound bradycardia, less than 30, and they require to be seen by a cardiologist, even when their heart rate appears to be quite okay. So the other one to calculate your rate is you look at the number of small boxes here, okay? Number of small boxes here, then you divide by 1500. So this one might be a bit confusing because this is the one that is used by the cardiac nurses, especially when they are looking at the patients who have pacemakers, because they use milliseconds, which is 60,000. Then you divide by your cycle length, then you get your beats per minute. So this one you leave it. Let's use the 1500 method, which is the 1500 small boxes. Then you divide by the number of small boxes in between the RR, and then you're able to get your rate. Okay. So I will move faster there. Then the other one is the 6-second rule. 6-second rule is, again, you will look at your ECG. Then you count 30 big boxes for you to get your 6 seconds. And then you count the RR interval. Then you multiply by 10. Then you get your rate. So our rate here is approximately 70 beats per minute when you're using the 6-second method. Okay. So the other one again is when you're using the big box again, then you count what is in between there, then you divide by 300, then you will get your rate. Okay. So now from rates, let's look at the other feature that you look at your ECG is the rhythm. So the rhythm, for you to get a rhythm, is you look at the RR interval, then probably look for a paper, you plot on those two, on the first RR, and then you go placing on all the RR interval that is there. So your rhythm will either be regularly regular, it will either be irregularly regular, or it also be irregularly irregular. So once you place that paper across there, it will tell you whether you have your rhythm is regular or irregular. And you allow me to move faster because of time. So your ECG interpretation would mean that the distance between one R to the other will be normal, will be equidistant. So you're able to get a distance between one P wave to the other P wave, or from one R to the other R, and that then you'll determine whether your rhythm is normal or whether your rhythm is regular or irregular. Okay. So a normal rhythm is a normal sinus rhythm that operates all the way from the sinoatrial node all the way to the Purkinje fibers. It follows the normal route, unlike these other ones. Okay. So the arrhythmias that you get are as written there. You'll either get a sinus arrhythmia, or you'll get a ventricular arrhythmia, which is a ventricular fibrillation or ventricular tachycardia, or your patient will have a pacemaker. A pacemaker, because it is the rhythm is not generated by the sinoatrial node. It is actually coming from either surface ECG. You will get a pacemaker rhythm. So you're able to get one because it is quite widened. Okay. And in terms of arrhythmias, you will get either atrial fibrillation, atrial flutter, junctional rhythms, or the or supraventricular tachycardia that you get. The other arrhythmias that you'll get is a first degree AV block. you may get the second degree AV block type 1, second degree AV block type 2, and third degree AV block. The last two are quite dangerous. This, when your patient has either second degree AV block type 2 or third degree AV block or complete heart block, this patient requires to be seen by a cardiologist. They require to be put a permanent pacemaker, because otherwise, if you are not, there's a likelihood of losing your patient. So the other arrhythmias will be ventricular fibrillation, could be ventricular tachycardia. This tachycardia also can be pulseless ventricular tachycardia. It can be polymorphic ventricular tachycardia, otherwise known as torsade de pointes. When the last two rhythms, if they do not have a pulse, this patient will require to be defibrillated. Same as ventricular fibrillation, they become lethal rhythms. When they have a pulse, ventricular tachycardia, and torsade de pointes, then you need to treat the patient to get to know what are the issues, so that you reduce the rhythm and probably the drug that is going to cause the rhythm to convert, basically known as cardioversion. Good. The other one, my name is not moving. Good. So the other feature is the axis. So we have looked at the rate, the rhythm, and the axis. Axis basically means the general direction of these impulses that actually follows, especially when it is oriented towards a particular QRS complex. So, and it will also depend on what your patient will be having. So a normal electrical cardiac axis is between -30 to +100 degrees. Okay, but that might become a tough one. The best way to know your patient has either a normal cardiac axis or a right axis deviation or left axis deviation is to use the leads in the next slide, lead 1 and AVF. Lead 1 and AVF, because lead 1 and AVF, they are at right angles. Okay, so when your patient has a lead 1 that is positive and a lead AVF that is positive, your patient has a normal cardiac axis. And we have said a normal cardiac axis is from -30 to +100 degrees. Okay, but if you forget -30 to +30, remember, you look at lead 1. Is lead 1 positive? What about AVF? If AVF is positive, positive means that it is deflected upwards, it will mean that your patient has a normal cardiac axis. Okay. In terms of a patient who has, in terms of left axis deviation, so left axis deviation is you look at lead 1 and lead AVF. So when lead 1 is positive and lead 1 is negative, then your patient has left axis deviation. So what causes left axis deviation? Left axis deviation is caused by any patient who has emphysema, patient who has hyperkalemia, patient who has something called Wolff-Parkinson-White syndrome with a right-sided accessory pathway. Wolff-Parkinson-White syndrome is a congenital anomaly a patient is born with. They have extra pathways in the atria. Okay, normally shown by something called a delta wave. When you look at your QRS, the S looks like a delta, like an upstroke, like a tick. It becomes a WPW. So The other one is the right axis deviation. Right axis deviation, when you have negative lead 1 and a positive lead AVF, that is a right axis deviation. So right axis deviation is caused by right ventricular hypertrophy, caused by chronic lung diseases, patients with COPD, patient with pulmonary embolus, patient with ventricular septal defect, they might get a right axis deviation. So we have looked at the rate, the rhythm, the axis, and we have seen and how you get to the axis. Now let's look at the other feature that you want to look is the P wave. So how does a normal P wave appear? So a normal P wave should be less than 2 to 3 millimeters in height, in amplitude. In terms of width, should be 0.11 seconds, should be gently rounded, should be upright in lead 1, 2 AVF, then from lead V4 to V6. It should be inverted in AVR, could be diphasic or inverted in lead 3, could be variable in lead AVL, V1 to V2. So that's how a normal should appear. In abnormal P wave is seen when you have atrial enlargement or dilatation of that atria. Of course, it will be increased in amplitude to be more than 2 to 3 millimeters. It is increased in width, more than 0.12 seconds. Could be an ectopic atria or AV junctional. It could be inverted, could be absent if you have AV junctional, or the SA node is blocked. So this is what actually is called the P mitrale or left atrial expansion. Could be diphasic, and that's how you see them in terms of your lead, your ECG lead 1. You see the lead V1 is inverted, and of course these are patient who is very sick that needs to be seen urgently by a cardiac specialist, by a cardiologist. It is notched at and widely notched at lead 1, lead 2, and it is tall in lead 1 more than lead 3 when you're looking at your ECG. Okay, so that is your P mitrale, or rather the left atrial enlargement. Then you have your P pulmonale, which is a pointed lead 2, lead 3, and lead AVF. And lead 3 would be taller than lead 1. And then your patient has a right atrial enlargement, of course, caused by any pulmonary issues, patient with COPD, patient probably with PTB. This is what you see in your ECG. So the other ECG feature is PR interval. PR interval, we said, is a passage of impulses across the atria, and we said the normal is 3 small boxes, not more than 5 small boxes. In terms of duration, 0.12 seconds, no more than 0.2 of a second. So, and we said PR interval, I've said it's the beginning of P wave to the beginning of QRS. Of course, I said the normal is 0.12 to 0.2 of a second. PR interval, of course, it's prolonged, could be a normal variant, prolonged in any AV block when you are thinking of first degree AV block, second degree type 1 AV block, second degree type 2, complete heart block. It's prolonged in patients who have hyperthyroidism, patients with Lyme disease. Of course, it's shortened in patients who have who have tachycardia, who have Parkinson-White syndrome, patient with the tumor of the adrenal gland, pheochromocytoma, patients who are hypertensive will have a shortened PR interval. So remember, PR interval is 0.12, not more than 0.2 of a second. So when it is prolonged, then it means there is a challenge. When it is shortened, it could either be a normal variant or there could be a challenge that you need to check on your patient. Good. From there, let's look at the PR segment. PR segment basically means a line between two waves. So between the P and the QRS, there is that PR segment. So it's the end of P wave to the beginning of QRS. It is normal, which is isoelectric. It is displaced when you have an infarction in the atria or when you have acute pericarditis. So we have looked at the rate, rhythm axis, P wave, PR interval, PR segment. Now let's look at the QRS complex. So QRS complex, of course, represent the ventricular depolarization, the passage of these impulses through the ventricles, the QRS. Normal, we talked of the limb leads, lead 1, 2, 3. So normal should be 0.05 to 0.1 in lead 1, 2, 3. In the chest leads, which is V1, V2 to V6, should be 0.06, not more than 0.12 of a second. 0.12 of a second basically means not more than 3 small boxes. In terms of the height, in the limb should not be more than 5 millimeters. 5 millimeters is 5 small boxes. In the chest should be not more than 10 millimeters, which is 10 small boxes. And of course, should not be less than 20 to 30 millimeters, two small boxes, 20 to 30 small boxes. In terms of the QF, normal but small should be less than 0.03 of a second. You seldomly, by the way, see Q wave. By the time you're seeing a Q wave, sometimes it shows an evolving MI. So you need to be wary of that. And you see that in V5 to V6, lead 2, we are to see, should be in V5 to V6, lead 2, lead 3, and AVF. So you'll get a wide complex QRS as a bundle branch block. There are some drugs that will cause the patient to have widened QRS. Patient with low voltage, a special patient who are obese, patient who have emphysema, pericardial effusion, pleural effusion, hypothyroidism. This one will actually show low voltage, meaning we said it could be less. In limb leads, we said it should be not more than 5 millimeters. In QRS, in terms V1 to V6, we said it should not be more than 10 millimeters or 10 small boxes. Of course, in widened in high voltage, of course, it will be high voltage means they are quite high in patients who have left ventricular hypertrophy, patients who are hypertensive, patients who have hypertrophic cardiomyopathy. So from there, we look at the QRS complex, the LVH criteria. So for you to get a left ventricular hypertrophy, the criteria that you use is that the SV1, when you add it to R, that is S in V1, when you add it to R in V5 or V6, it should not be 35 millimeters, 35 small boxes in a 30-year-old. should not be 40 millimeters or 40 small boxes in a 20 to 30-year-old. In a 12-year to 20-year-old, it should not be 60, more than 60 small boxes. In the terms of precordial, which is a chest lead, R plus S, the other criteria, R plus S, should not be more than 45 small boxes, or in R in lead 1 should not be 14 millimeters, which is 14 small boxes, or in R, which is our AVL, should not be 12 millimeters. Left ventricular hypertrophy, of course, will show that the left side of your patient is hypertrophied, and you get to know that the patient is having left ventricular hypertrophy when you actually show what I have just said. In terms of right ventricular hypertrophy, R in V1 plus S in V5 should not be more than 10.5 millimeters. And of course, the other criteria that help you to know that your patient has right ventricular hypertrophy is right axis deviation. And we rightly said what you look to get to know that your patient has a right axis deviation. The other ECG feature that we need to check is the ST segment. The ST segment, of course, is you look at the J point or the QRS takeoff or to the beginning of T wave. It should actually come, goes down and come up, goes to a plateau or to an isoelectric line, so that now it goes to your T wave. It should be less than 1 millimeter elevation in the limb, should be less than 2 millimeter elevation on the chest lead. Chest lead, remember, is V1 to V6. And in terms of depression, should not be less than 0.5 millimeters or half a box, half a small box. Okay. In terms of depression, the causes would be myocardial ischemia. When myocardial actually is has a challenge in terms of supply of oxygen. Patients who have hypokalemia. It is elevated in patients who have myocardial ischemia, acute pericarditis, hyperkalemia, Brugada syndrome, and of course, there also could be early depolarization. So in your ST segment, okay? So early repolarization, you see it in 2 to 5% of population, is a normal variant in a younger population. Of course, your ST elevation should be an upward concave pattern. You will see tall peaked T wave, and you are seeing this in precordial leads, V3 to V4, and also you'll see in other inferior leads and anterior. And of course, the other thing is that there will be no reciprocal depression, meaning that you are not worried that your patient has either an ischemia or your patient has an MI. So the other thing you need to consider is this one shows basically to show what you look at when you are looking at your patient who has early repolarization. So you're looking at your J point, and then of course you look at that apex to get to see what your patient has. So you have looked at all that. Now let's look at the T wave, and I have some few minutes. I want to indulge with you. You had me some 5 minutes so that I finish in the next few minutes. The T wave. Of course, we said as we are starting is a ventricular repolarization. Should be normal, upright in lead 1, 2, V3, and V6. Is inverted in AVR lead. Of course, is variable in lead 3, AVF, lead V1 to V2. It should be less than 5 millimeters in limb leads and less than 10 millimeters in chest leads. So T-wave is sharply pointed symmetrically in patients with MI. Of course, it's tall in patients who have hyperkalemia, patients who have MI, who have ischemia, patients who have central nervous system disorder. It's flattened in patients who are obese, patients who have hypokalemia, and of course must be accompanied with an U-wave. A T-wave is inverted patients with MI, patients with ischemia, and of course patients who have CNS disorder. So let's now look at QT duration. In terms of QT duration, of course, you look at your QT interval. It's a beginning from the beginning of QRS to end of T-wave. Of course, shows the total ventricular plus repolarization and depolarization in your patient. It should be normal in males, less than 0.44. And of course, you start worrying in females when it is more than 0.46 of a second. Of course, seen in patients who have issues to do with genetic mutations, could be idiopathic. You might see it in patients who have electrolyte imbalances, shortened in patients who have genetic mutations, patients with hyperkalemia, and patients with hypercalcemia. So in terms of U-wave, which is our final wave of ventricular repolarization, you see it is prominent in patients who have hypokalemia, patients who have who are on drugs, quinidine, phenothiazines, and it's negative in patients who have MI and left ventricular hypertrophy. I am glad that you have stayed the course for the last 1 hour, 5 minutes. I've come to the end of my presentation today. I hope we have gained something that is going to help us in terms of helping care of our patient. You do not get worried when you see an ECG strip. You can be able to do a simple interpretation even before you refer your patients to a specialist. So I want to leave it there and get to see whether there are any questions. Karibu Linet.
Thank you, Mr. Njenga Kamami, for that very insightful lecture on ECG and its interpretation. I know that we have gained a lot of knowledge, and we will use it even in our various areas to even make the lives of our patients better by quick diagnosis and even monitoring of heart conditions of our patients. We know that ECG actually guides and treatment decisions. It helps in early diagnosis of various arrhythmias. And when we take this, even as healthcare workers, we are able to sort our patients in good time. So we really want to appreciate Njenga Kamami for giving us this insightful presentation this afternoon. We also want to thank you all the participants for staying the course and being able to listen even to this very important lecture. We want to also extend our thanks to the KNH that has made it possible for us to make this presentation. The nursing team in KNH, we want to also thank the research and innovation for making this presentation, for making us be able to do this presentation this afternoon. We want to appreciate you once again, the participants, for being in and staying the course just to listen in to this very important presentation. Without much further ado, I realized that some of you had said that we were not audible, but this has come in late in the day because I thought it came out earlier and we did what we needed to do to make sure that we could be heard. Anonymous attendee wants to know, John, when do we shock the patient?
Thank you very much for that question. I said when a patient has ventricular fibrillation, that is a shockable rhythm. You will need to shock your patient. When your patient has a pulseless ventricular tachycardia, meaning that you can see a rhythm that is ventricular in origin, it will be your responsibility to check whether your patient has a pulse. If your patient does not have a pulse, you will start the chest compressions and then prepare to give a shock. You give a shock of, depending on the machine that you have, could either be 200 joules or some machine will give you 360. So we look at what your manufacturer has recommended that you can use to shock your patient. Thank you.
Thank you very much, Njenga Kamami, for that answer to our participants this afternoon. Caroline Masinde wants to know what is the treatment for left ventricle dysfunction?
All right. Masinde?
Masinde Caroline, yes.
Thank you, Caroline Masinde. Because there could be so many issues that your patient might be having. Like I said, there are so many things that might cause the left ventricular hypertrophy. We talked of probably a patient would be having emphysema, a patient would be having maybe hyperkalemia. So the treatment will follow on what your patient has. So you really need to look at other causes that your patient has. So probably, and then you treat that cause. Once you treat that cause, then the left ventricular hypertrophy would be treated.
Thank you, Njenga Kamami, for that feedback. Anonymous attendee also wants Njenga Kamami to expound on the inverted P waves.
Okay. Thank you. Thank you. You said anonymous.
Anonymous.
Yeah. So we talked of the inverted P waves. It will actually, the issue here would be either your patient had we talked of P mitrale, or your patient could be, so your patient has a P pulmonale. That would mean that your patient has a pulmonary issue. And I talked, your patient has things to do with maybe COPD. Your patient could have maybe TTB issues. So they are seen on that particular part of the heart, and they are caused by the anomaly that your patient has. So then you will need to investigate further to see what your patient has. Remember, our topic today is ECG becoming an important diagnostic tool. So it points you to know that this is what your patient has. So probably you need to do other supporting diagnostic tests that are going to help you in coming with the clear kind of treatment that you need to institute on your patient. Thank you.
Thank you, Sarah, for your questions. I can see you want Njenga Kamami to maybe shed some light in view of a patient who comes in with MI and has chest pain. I don't know what you mean, but you want to know whether we should always suspect MI in a patient who has had MI and has come in now with chest pain.
Thank you very much. I didn't get to know the name. Oh, Sarah, thank you. I think I will concur with you. Any patient who has had maybe a history of maybe MI, I will suspect if they come with chest pain. And that's why I would be not very quick to actually even discharge the patient. That patient requires to be done probably on the bare minimum an ECG, so that you can get to actually pick if they have any issue that need to be addressed before they get home. So yes, it is important. Any patient who has a history of myocardial infarction, they should not just be left to go before you have fully investigated. Thank you.
Thank you, Njenga, for that feedback to Sarah. Anonymous, I don't know why you didn't want us to know your name. We seem to be having so many questions. Now you want to know where you can do ECG as a short course. Njenga, could you be having any response to Anonymous?
Thank you.